Díolíomh go léir Armagin. Today is the 17th of November, and I'm delighted to welcome you all to 30-year celebration of research in St. John of God. And this is the second day. Today, the topic of the conference is well-being during a crisis. Just over 100 years ago, on this day, the 17th of November, in a small town in Alaska, the Spanish flu, which was very deadly, killed almost the entire village, leaving just a few children. However, despite that tragedy, it allowed a researcher from San Francisco to study a lot about the virus that has led to ongoing medical research. I guess what we have to remember is out of every dark cloud, there may be a silver lining. And I think that is part of what St. John of God Research and Clinical Services continue to do with their mission. It is a beautiful morning this morning. Lucina Clinic Ragar is always a lovely place to work, and it is particularly beautiful with all the autumnal colours. I hope it is nice where you are, and I hope that you will be able to join us and relax from your busy and pressured work that you have been doing, which we thank you for, and enjoy the star-studded cast that we have for you this morning. I will introduce each of the speakers just before their talk, and we will be followed by a panel discussion where some of the questions you have sent us will be able to be discussed. My name is Professor Fiona McNicholas, and I'm a child and adolescent consultant psychiatrist working in Lucina Clinic Rathgar, Crumlin Hospital, and also affiliated with UCD. I am delighted to present the first speaker, who needs no introduction. Professor Brendan Kelly really is one of the most expert, learned, well-published and clinically experienced clinicians that I am delighted to know. He is Professor of Psychiatry in TCD and Visiting Professor in UCD. He is Consultant Psychiatrist at Tala, and he holds many masters in epidemiology, healthcare management, Buddhist studies, and doctorates in medicine and history, along with higher education degrees in governance and law. Brendan, we're very much looking forward to your presentation this morning, which is coping with coronavirus, mental health, mental illness, and the COVID-19 pandemic. Thank you.
Hi, my name is Brendan Kelly, and thank you very much for asking me to speak today. I'm going to talk for a little while about coping with coronavirus, mental health, mental illness, and the COVID-19 pandemic. I realize this is a topic that we hear a lot about, but I'm going to try and summarize some of the research and talk through some of the implications and the things that we can practically do to help. So to begin with, I'm going to talk a little bit about the psychiatric and psychological impact of COVID-19, managing mental health at this time, and then I'll boil it down to 5 tips for mental health. And these are things for ourselves, for me, I need to do them as much as anybody, but also that we can share with patients and families and the like. And I'll finish up with some resources that we can use. So we'll start with the psychiatric or psychological impact of COVID-19. Now, there's been a bit of research about this, and particularly I'll go back to some of the early research which came from China, unsurprisingly, where this is an online survey of about 1,200 people in 194 Chinese cities. And what they did here was they just contacted 1,200 people and asked them about their emotional state, their psychological state. And people rated the impact of the pandemic on their mental health. So these are the percentages of people who reported a moderate to severe impact in terms of overall psychological impact, anxiety symptoms, and depressive symptoms. And what we see is when you contact people in this way, pretty much 1 person in every 5 will say that the pandemic has had a moderate or severe effect on their mental or psychological well-being. Now, this kind of research clearly has its limits. If you email someone or you telephone someone in some of the surveys and you say, has the pandemic caused you psychological suffering? A great number of people are going to say, yes, it has. The real discriminatory power lies in distinguishing what is and is not more than one would expect, or what is or is not disabling, or what is or is not clinically significant. So that's the challenge with these studies. But there is a continuity across the research that around 1 person in 5 will report an effect that is over and above what they might expect or what might be deemed to be a reasonable impact of the pandemic. If we look at some of the Irish research here, the Maynooth University and the psychology department in Trinity did a survey, again quite early on in the pandemic, looking at 1,000 people from a panel that they survey, asking about the clinically meaningful mental health problems. And again, you can see that for depression, anxiety, and PTSD, around 1 person in every 5 reports a clinically meaningful psychological problem above and beyond what they would expect. There's a good lot of overlap there between those with depression and those with anxiety. So this is population well-being, population psychological health, as opposed to mental illness. But the surveys are nonetheless interesting as indices. So who's most at risk? Looking at the research as a whole, among the general public, the risk factors for poorer mental health outcomes or psychological health are female gender, being younger, and pre-existing poor health. And of course, we keep hearing about pre-existing conditions being a risk factor for COVID-19, particularly for bad outcomes and more difficult hospital courses. Younger people do tend to cope less well with this than older people. Now, people over the age of 70 are in a somewhat different category, but broadly speaking, it's younger people. And female gender is an interesting risk factor for less psychological health at this time. And it is, of course, consistent with the finding that depression is diagnosed twice as commonly in women as it is in men. So what about population mental health then? What should we do for the country as a whole, if anything? This is obviously quite a tricky one. There was an ocean of research following 9/11, and it's very clear that for the general population who are not exposed to specific personal trauma, people tend to cope best on their own with their families and their friends and their communities, but they need to know the door is open if further help is needed. And that's very much the case for most people in the categories that I'm talking about here, that we do need to provide sort of the tools for people to help themselves and to support each other, but there's not much point in declaring that 1/5 of the population is mentally ill. It's not accurate, it doesn't get anybody anywhere, and it fails to acknowledge the true nature of the suffering and how it can be relieved. The Central Statistics Office has some interesting figures on this too. They do a really good survey of thousands of people, and they ask, do you feel depressed some, most, or all of the time? And in 2018, you can see the numbers there. 13% of people, more females than males, reported to the CSO survey they felt depressed some, most, or all of the time. 2020, this is in June of this year, in the midst of the pandemic, these numbers have predictably gone up, 26% of men, 39% of women, and overall 1 in 3 people saying they're feeling depressed most or all of the time. So what does this translate into? Is this mental illness? Is this unhappiness and frustration at the pandemic, at the restrictions and all of this? Well, the College of Psychiatrists of Ireland did a really good survey that's online, and they found toward the start of this that 64% of psychiatrists reported increased self-harm or suicidal ideation at the start of the pandemic. Now, what does this mean particularly? Well, one of the other ways of looking at this is to look at the rates of presentation to hospitals with deliberate self-harm, because that survey result from the College of Psychiatrists includes suicidal ideation. And we know from the CDC in the US that in the US, the CDC surveys have found that 11% of Americans have at some point thought life is not worth living during the course of this pandemic. So suicidal ideation is quite a different thing to acts of self-harm. And when we look, here's a report from the Irish Examiner on the 11th of September, and the sort of headline from this is that the early data indicates no rise in suicide during early lockdown. And in fact, hospital presentations with deliberate self-harm fell by 25% in the opening months of the pandemic earlier in 2020. Now, that's not quite what it seems, because hospital presentations with everything fell between 25 and 30% during the opening months of the pandemic. But what it does suggest is that presentations with deliberate self-harm have not differed from general hospital presentations during the early months of the pandemic. And what about completed suicide? Has that changed? Well, it's too early to say because figures are slow to come in. But this article did include a rather interesting comment from Mary Flanagan, president of the Coroners Society, who said that in her experience in Covet and South Monaghan, she did not feel there was a suicide epidemic during the pandemic, and that the numbers appear stable for the past 6 months. And this was a report in the September Irish Examiner. So in terms of suicide, it's not clear. The history of suicide statistics suggests that there mightn't be a huge change. Now, most of you will know this already, but I will go through it here now. This is the world rate of suicide. You can see here 1990 is on one side at the bottom and 2017 on the other. And this is the rate of suicide, the number of suicides per 100,000 population in the world. The middle line, the red one, is everyone. The upper green line is males and the blue one is females. And if you look at the red line, what you see here is in 1990, the rate of suicide around the world was 15 per 100,000 population per year. And by 2017, that had fallen to just under 10 per 100,000 population per year. So in other words, the rate of suicide around the world is falling very dramatically. It fell by a third between 1990 and 2017. And you can see it's falling in males and falling in females. The rate in males is higher than females, but suicide in the decades leading up to this pandemic has been steadily falling. Now, a couple of things bear mentioning here with these figures. It's not quite even. In some countries, it's falling quicker than others. And those figures include one big country where suicide hasn't fallen by a third, but has increased by a third in those years. And that country is the United States. It has moved contrary to the global trend on suicide. But even including the US, globally, it has fallen by a third between 1990 and 2017. That fall is also apparent in Ireland. So suicide has been on the way down, and that's the context in which we need to consider any increase or any fall or any stability in rates during the pandemic. The other important point to make about suicide is to take this graph back further and look at it over the course of the last century. Here's a suicide rate in the US only. The last slide was the world. This is the US, 1907 up to 2017. And watch, the vertical axis here does not go down to 0. It only goes down to 10. But it's the same number otherwise, the rate per 100,000 people. And if you follow that red line, you'll see that the big fall there happened during there was a fall during World War I. That's the first big dip. It went up again. It fell again during World War II. It went up again, but it never went up as high as it had been prior to the war. And there you can see at the end that increase I mentioned in the US at the very end that is contrary to the global trend. So world wars produced diminution in suicide, partly because a lot of the at-risk people were at war, young men, partly because roles changed very dramatically, particularly for women who were at home and had greater, or at home as in their home countries, not serving in the army, but had greater responsibilities in workplaces and factories, and that seems to have helped. But suicide fell during the two world wars. Another possible reason could be community cohesiveness, which was increased. And it will be very interesting to see when we get suicide statistics for now, just how it happened. Now, I should emphasize, of course, that even one suicide is one suicide too many. And when I say that the rate has fallen by a third, that is by no means enough. We need to work much, much harder. But it does prove that suicide rates can fall. And we should tread carefully during the pandemic to make sure that we provide the supports to those who need them and try and continue that trend. So that's population mental health. That's everybody. I'm going to focus now for a quick minute on healthcare workers. And again, if we go back to some of the early research in China, this is a study of about 1,200 healthcare workers, which found that almost 3/4 of healthcare workers expressed clinically meaningful levels of distress, 50% depression, 40% anxiety. If you look at the totality of studies about this, approximately 40%, that's about double the population rate of healthcare workers report clinically meaningful psychological problems as a result of the pandemic. The risk factors, again, female gender, working as a nurse as opposed to another kind of healthcare professional, a lot of frontline time, and then working in areas like Wuhan. So that's healthcare workers, a rate of clinically significant psychological distress of about 40%, double the population rate. And of course, there are all these additional issues that are of concern to healthcare workers about, the availability of PPE in certain countries, tensions about rosters, shall we say, financial issues, and of course the worries about bringing COVID home to your family, all of which are relevant to varying degrees here in Ireland too. Now, I have to say there is a very good editorial about this available, free of charge, of course, in the Irish Medical Journal, written by our colleagues who you see there on the screen. And also there's a whole series of papers in the excellent Irish Journal of Psychological Medicine special issue on COVID-19. Again, this is the College of Psychiatrists of Ireland journal. It's available online, and all papers are open access, free to access. So everything I've spoken about so far has been about the effect of COVID-19 on patterns of mental illness, mental distress. A lot of attention has been devoted to this. Far less attention has been devoted to the impact of mental illness on the pattern of COVID-19. And that's one of the things I really want to highlight today, particularly in the context of a paper that just appeared in the journal World Psychiatry, which is, again, World Psychiatry is it's free to access online. And this is a really interesting and important paper about the risk of COVID-19 infection, hospitalization, and mortality in people with mental disorders. And these researchers, it's a US study, they looked at a huge database, millions of people in the US, accounting for a coverage of 20% of the entire, 20% of the entire population of the US. Their medical records were analyzed for this study. And to put it in a nutshell, I've highlighted in red there, patients with a recent diagnosis of a mental disorder had an increased risk of COVID-19 infection. For depression, the odds ratio was 7.6, and for schizophrenia, 7.4. Those of you who like statistics will see those figures have really tight confidence intervals. So these are very reliable findings. What this means is somebody with a recent diagnosis of depression or schizophrenia, the odds of them getting infected with COVID-19 are more than 7 times the odds of someone without such a mental illness getting infected with COVID-19. And this analysis controlled for age, for gender, obesity, and pre-existing medical conditions. So even when you take the distribution of those things into account, people with these diagnoses have more than 7 times the odds of being infected with COVID-19. Similar odds ratios apply to other conditions, though not quite as high. So the odds for someone with ADHD, for example, their odds of being infected with COVID-19 are 5.8. It's almost a 6-fold increase in the odds of COVID-19 if you have ADHD. And for bipolar disorder, it's 5.7. Again, all of that is after controlling for age, gender, obesity, and pre-existing conditions. There's also an increased risk with these diagnoses of requiring hospitalization for COVID-19 and an increased risk of dying from the infection. So what we've neglected in a lot of our discussions to date is the effect of pre-existing mental illness on the distribution, the pattern, and the impact of COVID-19. And this is a headline finding, and it is a rather important one. And of course, it speaks to what we already know, which is that people with mental illness have difficulty accessing physical health care and difficulty accessing public health advice. So difficulty accessing physical health care, we know that men with schizophrenia die 15 years earlier than men without, women with schizophrenia 12 years earlier than women without. And for the public health advice, we know that people with enduring mental illness have very high rates of smoking, and public health advice to stop smoking doesn't seem to impact as it should. That's one of the effects we're seeing with the numbers I've got on your screen there. We live in an era when adhering to public health advice is vital, and it would appear public health advice about COVID-19 is having just about the same amount of impact that public health advice about smoking has among many people with mental illness. And that's something, it's a role obviously for us as community mental health teams to try and get messages out there about these things to the people who attend our services. So that's a little talk about the psychiatric impact of COVID-19 and, if you like, the impact of mental illness on the distribution of COVID-19, which is a neglected topic. Managing mental health during COVID-19. Well, I am, as is almost traditional now, going to draw attention to this resource. I wrote a short book about this at the start of the pandemic called Coping with Coronavirus. We wanted to make this book free, but it turns out it's not possible. So the ebook costs just €1. Royalties go to the Red Cross, and you can just download it onto a phone or anything from Amazon or where have you. And they're also printed, or if you can tolerate the sound of my voice, which I appreciate many of you can't, there is an audiobook with me ranting my way through it. The book focuses on practical strategies to try and manage mental health. This is aimed at the 20% of the population who are experiencing more distress than they should, rather than, if you like, people with severe mental illness. This is about managing well-being. And I've broken it down into managing knowledge, how we think about things, managing our feelings. Behavior is very, very important. Actions. That point number 4 is doing, and not, as my daughter tells me, doing. It is doing and things we can do to help. And finally, being. This tendency that we have to think about this pandemic not so much as a big public health problem needing a big solution, but our tendency to think about it as an existential crisis for humanity, which it might well be, but there's absolutely no point getting too caught up in that when what we need to be doing is wearing masks, washing our hands, and supporting our patients to follow the healthcare advice. Rather than talking you through the entire book, what I'm going to do today, you will be very relieved to know, is I have reduced this down to just 5 key tips that I think are important for us and for our patients. The first thing is this talk about the new normal. It's not a very helpful phrase. There is nothing, and there never will be anything normal about this. This is a tough time and a strange time, and we need to give ourselves and each other's more permission to be upset and be distressed by it. It's understandable, and we need to give a bit of airtime to that. We cannot carry the weight of a global pandemic on our shoulders every minute of every day, as many people are trying to do. We should limit our media intake about the global pandemic to once or twice a day, 15 minutes maximum. There's no point in carrying this with us every minute of every day, and a lot of people need to take that advice. Obviously, routine is very important, things like diet and exercise and staying in touch as best as possible. We tend to neglect behavior at times like this. We spend all our time thinking and analyzing statistics, scrolling through social media, looking for the most unlikely possible theories, and then we dismiss them, but they still have an emotional impact. Getting out of our heads is so important. We're hypercognitive. We live in a hypercognitive era. Our brains, with 86 billion neurons and trillions of synapses, are vastly too complex for us to understand or to deal with. So we need to get out of our brains as much as we can. Going outside is a really good way to do this. Another way is getting into something, getting into a state of flow or absorption in any activity that you like. Now, traditionally, we talk about mindfulness and meditation, and that's all very good, but some people find that just irritating, if I'm honest. A lot of activity achieves mindfulness, but just without the lingo. So when you talk to people who go running, for example, they often say when they're running, they have no thoughts, there's just the movement, the motion. And that is, in fact, a state of mindfulness and absorption. The same applies to gardening, especially for older adults who mightn't be able to go out that far. Knitting is also very good. And of course, the mindfulness and the meditation. But a lot of people find that meditation and mindfulness evokes these kinds of unrealistic images of, states of enlightenment and levitation that just will never happen. Schools have some very interesting mindfulness programs, but let's not forget the other things that we naturally do that bring us to this state of absorption. I've given the example of running and also a rather updated and modern example of knitting, which can be a uniquely absorbing activity for people who are into it. So what I really wanted to talk about today was the psychiatric impact of COVID. The pandemic appears to have given around 1 person in every 5 psychological distress that they regard as too much or difficulty coping with. For healthcare workers, that's around 40%. It's around double that. So we need to be mindful of how we support our colleagues, how we support ourselves, our families, and so forth. Let's not forget the impact of pre-existing mental illness on COVID and the patients that many of us see with schizophrenia and bipolar disorder. They do need extra public health advice and encouragement to follow it, as we know is the case with stop smoking advice already. In terms of managing our mental health, we do need to devote a little bit of time to that, try and avoid too much media exposure, engage in some good behaviors, particularly becoming absorbed in activities that we like. There's some really good resources from the HSE. The CDC in the US, their website is really good, and they have a workbook talking with children about coronavirus disease. That is really good for people who struggle to know what to say to parents who have children or what to say to children. Inclusion Ireland and Cheeverstown have some good online resources regarding intellectual disability, Nursing Homes Ireland and Parents Plus as well. Obviously, I'm not going to finish without giving a further mention to coping with coronavirus, which you can download from Amazon and so forth. And to finish with the final flourish, some of you may be familiar with this figure, Professor Anthony Clare. This has absolutely nothing to do with COVID, I'm afraid, but myself and Maurice Houston have just co-written a biography which is available for those of you who are keen. As I say, the Coping with Coronavirus book, just €1, proceeds to the Red Cross. So look, thank you very much for speaking to me today. I believe there will be a live questions and answers a little bit later on, but thank you for your attention, and hopefully we can talk later. Goodbye.
Thank you, Brendan, for your mix of practicality and resources balanced with the very strong evidence base. I would now like to introduce our second speaker, Dr. Joseph Duffy, the Chief Executive Officer of Jigsaw. Joseph has an MBA from UCD and his Doctorate of Clinical Psychology from TCD. He has 20 years' experience of managing mental health services, and as Director of Clinical Support for Jigsaw, he's played a lead role in managing that and is very familiar with the area in which he is presenting to us today. Joseph, I'm looking forward very much to your talk, which is on youth mental health. What does the future look like? Thank you.
Hello, I'm Joseph Duffy. I'm the CEO of Jigsaw. I'm going to talk to you today about youth mental health. What does the future look like? Why is youth mental health a concern? Some of you, and many of you, may know that the onset of mental illness peaks around adolescence. We know that about 50% of mental disorders develop before the age of 15 years and 75% by the age of 25. So being young and the idea of being young and experiencing a diagnosis or difficulties around mental health is something that happens to a significant number of young people. When we think about the population of Ireland, we think about young people. The CSO have done some projections based on a 35-year timeline. So the created 6 different scenarios, and their assumptions would suggest that the population of Ireland is going to significantly increase over the next 35 years. So we know the combination of what I was saying there about being young and the combination of a growing population are leading to, I suppose, 2 factors to suggest to us that we need to think more about young people and their mental health. But adding to that, thinking about this in an Irish context, this is some evidence from work that Jigsaw did with UCD around the My World survey. So in 2012, we conducted the largest ever survey of young people's mental health using a range of psychometric measures. And this is data comparing 2012 with 2019. So between 70 and 60% of young people were experiencing normal levels, in this case of depression, in 2012 and 2019. What we can see as the figures look, and these are repeated again for anxiety and for other levels of mental health concerns, that the number experiencing mild levels of depression went down, those experiencing moderate, severe, and very severe increased. So what is all that telling us? It's telling us that mental health, and particularly youth mental health, is an area we need to become concerned about and involved in. So what's been the response? Over the past 15 years, there's been significant response worldwide, and particularly within the English-speaking world, focusing on services that are dedicated to young people. Jigsaw is one such service in Ireland, and I'll talk a bit about that. In Australia, we have Headspace. In Australia, we also have Origin, who focus on, particularly on young people who might need support around early development of psychosis, focus on policy and upon research, and Foundry, which is based in British Columbia in Canada. All of these organizations are working together, but they're also working very much focused on supporting young people and supporting those young people within communities. What are the key characteristics of youth mental health services? Over the past number of years, we've been, I suppose, put together a lot of knowledge, particularly based on an international cooperation from the International Association for Youth Mental Health, which focuses on these 7 factors which impact or really strengthen youth mental health services in the community. The first is having a basis in primary care. That's really important in terms of the entry level or the first level of formalized mental health support, that youth mental health services need to be at that level. Most of the mental health services are focused on a prevention, early intervention model. This care needs to be integrated in some of the services, particularly in Australia. They're connected in with employment services and with education services. In Ireland, it's very much connected in within the primary care and the health network. All those services need to have a youth-centered philosophy, so an understanding that a young person are at the center of the work that we all do. Accessibility is not just the physical accessibility, it's about how referrals are made, how you can come in contact with the service. Can you do that virtually? Can you do that in person? Do you need a referral letter? And how accessible are they, or where are they based within a community? The facilities themselves need to be very youth friendly, so they're not based in the traditional mental health settings, which might have been in a large psychiatric hospital. They're very much embedded and part of the community and connected to the community, not just to, mental health services, but to connect it to all elements of the community. Very strongly, what's behind a lot of these services and the philosophy and the way of working is very much an evidence-based care model, which really has developed that evidence base over the last 15 years. Particularly, I suppose, turning and focusing on Jigsaw in Ireland. Jigsaw is Ireland's leading youth mental health charity. With the support of the HSE and Sláinte Care and fundraising, we provide a range of free primary care mental health services and supports to young people, and indeed to their parents and families within community. Primarily, we're probably best known in terms of providing free one-to-one therapeutic supports across 12 centres across the country. We also provide community-based programs which very much are focusing on strengthening and supporting communities to empower young people and those around them to really promote a preventative model for youth mental health. These are focused on working with young people where they live, learn, work and play. We have significant pioneering research, some of it in the My World survey that I mentioned, and then robust evaluation in terms of the evidence that we have and how we evaluate the services and everything that we deliver. We've increasingly providing e-mental health supports online through jigsaw.ie, and we've rolled out a comprehensive secondary schools program called One Good School, aimed at supporting the mental health and well-being of young people by developing the shared responsibility for mental health across a whole school community. This is a map which gives you a sense of the services around Ireland. We have 12, as I mentioned already, open and seeing young people. We have 2 in Wicklow and 1 in Tipperary. Last year, we would have seen about over 6,500 young people providing over 30,000 individual sessions. We would have seen supported nearly 40,000 people since we first opened 14 years ago. But obviously, that's been cumulative, and much of that has been supported, and many of those young people have been supported in the last 15 years. Sorry, in the last 5 years. What impact did COVID-19 have on Jigsaw? It had a significant impact. In March of this year, most of our services were delivered on a face-to-face basis in a setting like this in Jigsaw, Dublin City. We had small number of supports rather, online. We were piloting a group chat program, but we had larger plans supported by Psychiatric to develop that further. You can see on the other side of the screen then what's happened now in November 2020. A significant number of our services are developed or provided through different modes. About half is face-to-face, about 30% on video, about 17% on phone. We've also developed a significant live chat, both individual and group offerings that will be 5 days a week, and also a number of evenings. The individual and the group chat is an anonymous once-off, one-session support for young people. We've also developed text and email support, and developed a national free phone number, and developed a significant number of webinars and seminars for parents, for teachers, and for young people. The reality is that through COVID, we have moved and pivoted our services to providing all of those supports, and many of them online or in a mode that's much more accessible to young people. We won't ever go back to having everything 100% face-to-face, and what we're continuing to do is continue to operate even through level 5 and having our face-to-face services open. Looking at some of that data then, in March, between March and July this year, here's an example of some of the presenting issues that young people came to us with. Between January and the 12th of March, before we suspended the face-to-face services, anxiety, low mood, and sleep and stress were particular presenting issues for young people. From the period from March to July, really, as was the period of the main lockdown before restrictions started to ease, you can see the other presenting issues again: anxiety, low mood, sleep changes. This time, family problems featured more, which isn't surprising within it. Looking at the key themes and feedback from young people, and some of these factors here wouldn't be that different from the general presentations that we see in Jigsaw. Anxiety, low mood, stress, and family problems certainly are common features of referrals to Jigsaw. Conflict between a young person, parent, and guardian is also there. What was a key feature and notable through COVID-19 was isolation from social and community settings, and also the social supports and peer networks for young people. About a third of young people would have said their mental health was impacted by COVID-19 and would have sought support from Jigsaw, but the remainder had pre-existing mental health concerns that maybe were exacerbated or increased by COVID-19, but certainly it wasn't the causal factor in those. I think it's important to note when we think about the impact on mental health and thinking about the impact of COVID-19 on mental health. We see in Jigsaw the demand has increased and has increased over the last 3 years, and it's that we wouldn't put that down just to COVID-19. There's a significant increase in the number of referrals each September and October, and that's reflected in the figures here for this year. But you can see year on year, there's about 25% increase each year. Those numbers are increasing and steadily growing. That's not a bad thing in terms of young people are continuing to reach out and connect with mental health services. So what does the future hold? We know demand is increasing. Stigma hopefully is reducing, so young people are more aware of the need for support. They're getting that support at an earlier age. One of the key things that is needed is about better integration across the whole mental health system. Jigsaw would see itself as at the prevention and early intervention side of a system of care. There needs to be much more focus on this prevention and on mental health promotion, on early intervention, but also on the use of technology, either through e-health, the phone video elements of that, or live online chat and support groups and direct supports. We also know that this area and the evidence base for it is growing and increasing, and there needs to be, I suppose, better focus on that. One of the things I wanted to draw some attention to, and given that this is a research conference, the International Association for Youth Mental Health set out some research priorities this year. There's 8 of them listed there. I want to focus particularly on 2 of them. What they're focusing on, and particularly their support from the Wellcome Trust, looking at treatment and novel interventions, particularly focused on youth mental health, and looking at, are there particular modalities or particular ways that we haven't tried or scaled up yet that would really work to support young people's mental health? And what is the role of new technologies in mental health, not just online or phone or video, augmented care? Is there other ways that we can work and support young people's mental health? And how do we look to blend those technologies in with traditional mental health supports, be they psychotherapy or other mental health supports together? What I wanted to do is to leave you with 2 quotes here. Jigsaw always asks our young people who attend our services and their parents, if they can, to give us their view on what the experience was like, both good, bad, and indifferent. And here's 2 quotes that I wanted to draw your attention to. I'll let you just read those there for a second. What we can see in those messages is that a young person is very much reflecting that they didn't think they would be able to talk, but they found the benefit of coming and speaking within a clinician, in this case in Jigsaw and Galway, was really beneficial. The idea that they would recommend anyone to go to Jigsaw as it helps in any way possible is really positive, because that's what we want. We want young people to be able to influence their peers, to talk openly and positively about their experience and about mental health, and if appropriate for them, to encourage other people to avail of services. I think the last one for me was indicative of how we're all working at the moment, and how this session in particular was over video for a young person, but that didn't seem to impact and certainly didn't impact negatively, and the young person was able to get the benefit from it, but that the parent is reflecting on the impact of the young person getting support, what positive impact and a great positive impact that has had on the whole family. So I think there are 2 nice quotes to end on. What I want to say is thank you very much for listening. Thank you for taking the time to think about the work that we're doing, and looking forward to having further conversations with you at some point. My email is there. Thank you very much.
Thank you indeed, Joseph, for your presentation. And it's lovely to see Jigsaw rolling out across Ireland, supporting specialist mental health services. I'd like to invite you all to have a 5-minute rest break, maybe get yourself a glass of water, a cup of tea, and to come back and to join us for the second session. Thank you. Welcome back, everybody. Thank you. I'm delighted to welcome our third speaker, Dr. Ruth Lone. Ruth is a consultant psychiatrist in old age and general adult psychiatry who is trained in the UK and in Ireland. She's fellow of the UK and the Irish College of Psychiatrists and indeed past president, and we've been honoured to have her working as consultant in St. John of God services. Throughout her career, she has been leading and developing services across Ireland in both community and liaison of old age. And Ruth, we're delighted to hear your presentation today on the impact of COVID-19 on older age persons. Thank you.
Okay, first of all, I'd like to thank the organisers for inviting me to give this talk. It is an interesting area and one which we're really very much in the initial stages of, but hopefully this will provide some examples and some knowledge around the impact of COVID-19 on older persons. So I'm a consultant in old age psychiatry in St. John of God's, and I've been here for the last 8 years. Prior to that, I was maybe 12 or 13 years a consultant in the HSE, again in old age psychiatry. So there's no doubt that 2020 has been a very difficult year worldwide. There has been an impact on all sections and ages of the population. For example, homeless people, travellers, school-going children, leaving cert class, university students, working age, adults, healthcare workers, and older people. Really, there's an impact on everybody in the population. There are certainly different stresses and impacts on differing countries around the world, between Europe, Australia, United States, and so on. I was delighted to see that Australia has eliminated the virus in the last week or so, and hopefully that will continue, and hopefully our current lockdown will have a positive impact on the rate of the virus infection in this country. And while we can learn many lessons worldwide, we also need to apply these to our own country and population, as everyone is different. Since March 2020 in St. John of God's, we have seen an increase in referrals and admissions in my department and for older people. And not only has occupancy increased, but also the type of, there have been changes in the types of presentation. So for example, we would normally have many more older women admitted than men, and equally to the outpatient clinic. Now we are seeing many more men. And we're also seeing more people with, who have no previous psychiatric history presenting with very significant illness. We're not talking about minor anxiety or health anxiety, but rather major depressive episodes with or without psychotic features, with suicidal ideation or indeed suicide attempts, and some with psychosis. We've also had people with dementia who have deteriorated as a result of the pandemic or the lockdown. So what I wanted to talk about was a number of areas, particularly the impact of the pandemic and on older people, and the impact of social restrictions or lockdown on older people. There's also the impact of the illness itself, and I'm not going to talk so much about that because that then we are looking at neuropsychiatric sequelae. I will talk a little bit about that at the end. I'll talk about some of the clinical presentations that we've seen, and also looking at reducing the adverse psychological impact of quarantine. I think it's really important that we look at how we manage that as well. There are certainly challenges for the delivery of mental health services for older people going forward, and certainly there are research opportunities in this area. So we know that with previous pandemics and large-scale disasters, whether they be traumatic, such as the World Trade Center, the natural disasters such as hurricanes or earthquakes or environmental disasters, there's an increased risk of depression, increased rates of depression, PTSD, adjustment disorders, and substance misuse. Certainly during the SARS epidemic, there was an increased rate of PTSD and psychological stress. Research has shown that there are increased rates of suicide in the USA during the 1918-1919 influenza pandemic, and during the 2003 SARS epidemic, there were increased rates of suicide amongst older people. For the COVID-19 pandemic, well, we're all aware of this data now. The first cases were reported in Wuhan in China in December 2019. After that, there was a rapid spread of the coronavirus right throughout the world. And on the 11th of the 3rd, 2020, WHO declared it as a pandemic. We locked down for the first time on the 27th of the 3rd, 2020, and we're now a couple of weeks into another national lockdown. Hope we are reducing the viral infection rates, but unfortunately, the numbers in the older people are now rising, and I see that the Chief Medical Officer only yesterday has expressed his concern about that. So with looking at the numbers from May 2020, of particular note are that 90% of those who died were over the age of 65. The median age of those who died was 83, and the median age of all cases was 48. So clearly there is an increased risk of mortality in the older age group because of their vulnerabilities and comorbidities. I've noted that there's a recent paper from South Korea which actually shows there's an increased risk of mortality in older people who have mental health disorder, which seems to be a risk factor in itself. Perhaps because they have a higher rate of comorbidities, it's not clear as yet. So as I said, we're focusing on mental health, really on the effects of the pandemic and the effects of quarantine or lockdown, and I will talk a little bit about the neuropsychiatry sequelae of COVID-19. So why are older people vulnerable? Well, they're vulnerable because of their associated comorbidities, hypertension, diabetes mellitus, heart failure, COPD. They have a less effective immune system, so they're more likely to get COVID. There's a potential limited access to healthcare now. Primary care is often by telephone, so this may not suit older people. There may be hearing difficulties, and so there's a potential for limited access. Social isolation, as we know, is a risk factor for depression, and with a pandemic raging in the environment, then there's increased risk of social isolation before we get to quarantine or indeed lockdown. I think one of the other issues is that in the media, certainly in the initial stages of the pandemic, every time you turned on the radio or the television, it talked about the vulnerabilities of older people and how they were more likely to die. And I know from talking to my patients that a lot of them suffered huge anxiety around that initial period because of that. Social distancing and quarantine causes social isolation, as I've mentioned, a risk factor for depression. There's a lack of contact with family and friends, and I speak with my patients, and very regularly they tell me about how they haven't been able to see their family, they haven't been able to hug their grandchildren. Sometimes they haven't even met their grandchildren. Babies have been born abroad and they haven't been able to visit abroad, or their family haven't been able to come back to Ireland. There's a lack of access to daycare centres, community centres, the churches are now closed. All of these places would have provided a social connectedness for older people, and this is a major difficulty for them now. Golf is closed now during the current lockdown. Again, a lot of older people used it as a social connection and find it difficult to understand why it's not allowed during this particular lockdown. The restrictions to visiting to nursing homes, I think, are particularly difficult. And I know this both from professional and personal experience. An extended member of my own family was in a nursing home and didn't have any visitors from her family for 5 months. which is very difficult for the individual concerned and also for the extended family. Window visits are being offered in some places, and in some places are not being offered. So there's a huge risk of isolation and also deteriorating cognition in people in nursing homes without the stimulation that their families can provide. I've mentioned here, again, the increased risk of depression, increased risk of cognitive decline, and certainly there's an increased risk of, or increased rate of BPSD in those with dementia. There have been, as we're aware, excessive deaths in older people in residential care, and this is something that will be looked at later, I'm sure. But one would wonder about how our nursing homes, in terms of the environmental issues, and how they can be more protected from this virus. Certainly, there's a higher risk of outbreaks in that setting. So, with regard to mental disorders, an early study carried out showed a prevalence of depression and anxiety of 37.1%. There's a higher risk in those who have had previous mental health disorders. There's an increased risk of psychosis, which has been shown in a number of papers. And with regard to dementia, there is an increased risk of cognitive decline and BPSD. I've listed some of the research that has been carried out to date. It's limited because we're very early in the time of the pandemic, and it's very hard to tell pre-COVID rates versus current rates. However, the first article there is about the increased rates of depression and anxiety during COVID-19 restrictions in older people with Alzheimer's dementia in retirement homes in France. Certainly, an overexposure to COVID-19 related news is associated with a higher level of depression, and I've already mentioned isolation. Positive coping strategies lead to lower rates of depression, and also there's an increased higher levels of anxiety. There's been one Irish study carried out during the first week of lockdown, which shows significantly higher levels of COVID-19 related anxiety in people over the age of 65. It was just carried out in the first week, so it would be interesting to repeat that again. When it comes to dementia and PTSD, there's an increasing irritability, agitation, and anxiety, a worsening of anxiety and depression in AD, and a worsening of hallucinations in DLB. There's also the increased stress-related symptoms in caregivers because their nearest and dearest, the people with dementia, have no longer anywhere to go during the day. There's no day centre, there's no respite, so that can cause difficulties for them. Disturbingly, there's an increased use of psychotropic medication for those with dementia, with all the adverse effects that this can have, and that is of concern. The survey from the Alzheimer's Society in UK looked at 2,000 people affected by dementia, and they found about a third had a sense of apathy or giving up. Clearly, this is of concern, and they also looked at the rates of the death rate and suggested that there was a higher rate of death because of this apathy or sense of giving up, because of the restrictions and the lack of visiting. I spoke a little at the beginning about reducing the adverse impact of restrictions. I think it's important, first of all, that the government put out clear communication as to what the pandemic entails, how the virus affects people, why there needs to be restrictions so that people are aware of it. I think some of the problems we had over the summer were that the people were not aware or understanding of what needed to happen in the future. Very important for people to stay connected by whatever means that may be, and it may be through digital technology. And we need to set limits to news and social media, because use of that can lead to further depression and anxiety. Support and routine, moving and exercise, these are all helpful in reducing the adverse impact. We know that time spent, and it has been shown in research on work, housework, gardening, exercise, etc., all can be associated with improvements in mental health and well-being. Mental Health UK suggested psychological first aid, which really is to provide support and connectedness and access to services. It's very simple, but it is a way of helping people to cope with the difficulties that they have. Two research studies here show that outdoor activities such as gardening and exercise lead to increased mental health and well-being, and an increased time following news about COVID-19 predicted declines in mental health and well-being. I'm certainly aware myself that you can get very sucked into looking at the figures every day, and then not only the figures in this country, you can look at the figures around the world, and it can become a focus and can become stressful and depressing. Looking at the challenges for the provision of services in the future. First of all, I think there needs to be an implementation of parity of esteem for those with mental illness and physical illness. The College of Psychiatrists of Ireland has been promoting this for quite some time, as indeed have the Royal College of Psychiatrists, and I think it's very important. We need to have a mental health monitoring system that includes outcomes related to mental health service use, and these measurement of outcomes should include both service users and their families. We need to prioritize existing services and promote new practices that expand cost-effective delivery of effective mental health services, which should be of high quality care, and they should be accessible. I have primary care support in. It really should have been at the top, because clearly that's the first port of call. It is very valuable for people to access mental health services, and maybe they don't need to be referred after they've been to primary care. So that's also very important. I'm interested that the Mental Health Commission have looked at some of the inpatient facilities and have said that they are not fit for purpose during a pandemic, and these are other areas that need to be looked at. We need to use digital technology where we can. Unfortunately, certainly some of my patients would not be able to manage video conferencing or remote video consultations, but they can manage phone consultations. When you're familiar with the patient, this can work very well. There is a couple of hospitals in the city now looking at inpatient at home initiative. It'd be interesting to see how that works out. And there are a couple of research projects going on in the northwest of the country using technology to support people either with dementia or with other forms of mental illness. I said I'd mention neuropsychiatric complications and just to outline what complications that can arise. Delirium is the most common. We know that during SARS and MERS it was 27.9%. The adverse effects of medication, steroids, can cause mania and psychosis. Certainly people who have had a serious illness are much more prone to depression, fatigue, anxiety, PTSD. COVID-19 can cause a hyperinflammatory state, and the link between inflammation and depression is well described and will be something that will need to be looked at in the future. There was one study of severe cases which reported that 1/3 had a dysexecutive syndrome, inattention, disorientation, or poorly organized movements in response to command. It's not absolutely clear what the cause was and how long lasting it was. So this is something that will have to be studied in the future. Future studies, really we should be looking at the prevalence of psychiatric symptoms in those with infection. We should try to do prospective studies so we can see the effects of the pandemic and the infection on older people. We should look at markers of severity of infection and perhaps correlating that with psychiatric symptoms. The long-term relationship between infection and post-infective fatigue or depressive symptoms would be an interesting area to look at, as would biomarkers of CNS infection using MRI brain, for example. We also need to look at the impact of the pandemic, look at the service use, types of presentations, and use qualitative research to try and outline what we can do to reduce the burden on mental health of older people. Lastly, which I haven't listed, I do think it's worth looking at nursing homes. I wonder about how we're looking after the older generation in nursing homes. where there's such an increased risk of such an infections and how we can reduce that, and whether there are other ways to provide long-term care for our older generation. I think I'll finish it there and say thank you very much indeed, and hope the rest of the day goes well. Thank you.
Thank you, Ruth, for highlighting the vulnerability in elderly, both with and without mental health difficulties, and for drawing our attention to the changing practices and presentations in your own service. I would now like to introduce Professor Mary Mccannon, who needs little introduction. Mary is Director of Trinity College Centre for Excellence in Ageing and Intellectual Disability. And she is an experienced researcher, both internationally and in Ireland, of course, in this area. She's probably most known for her seminal role as founder and principal investigator of the first ever longitudinal comparative study of aging in persons with intellectual disability, which is a supplement to the Irish TILDA study. She's been an advocate for individuals at all levels and ensuring that the voice of those with intellectual disability is clearly heard. Mary, we're looking forward to your talk this morning on the impact of COVID-19 on those with intellectual disability. Thank you.
Thank you very much, and I'm delighted to present here today on COVID-19 and older adults with an intellectual disability, and really the perspective from the Trinity Centre for Ageing and Intellectual Disability. Many of you may be familiar with the Trinity Centre for Ageing and Intellectual Disability. It's the first dedicated centre to investigate key issues in ageing, intellectual disability in the life course. It's underpinned by the Intellectual Disability Supplement to the Irish Longitudinal Study in Ageing, IDS-TILDA, which many of you may be familiar with. Indeed, we have many participants from St John of God services. And the centre is very much focused on advancing world-leading research, scholarship and training to identify the determinants of health and well-being for adults ageing with an intellectual disability. On IDS-TILDA, it's now in its fourth wave, so we have nearly 14 years of really good health data. And the objective was to understand the health characteristics of people aging with an intellectual disability, to examine the service needs and healthcare utilisation of people aging, to identify the disparities in health of adults with an intellectual disability as compared to TILDA findings for the general population, and to support evidence-informed policies, practices and evaluation. And having the data from IDS-TILDA was really critical and fundamental to our understanding of risk factors for people with an intellectual disability during the pandemic, because now we had really good health data and social care data as well on this population. So when the world changed in January the 30th, 2020, the World Health Organization declared an outbreak of COVID-19 to be a public health emergency of international concern and declared it to be a pandemic on the 11th of March 2020. So the Trinity Centre for Ageing and Intellectual Disability tried to respond and to assist services throughout the country and indeed throughout the world, informing people with an intellectual disability, developing a host of easy materials on symptom issues around protection and self-isolating, on testing, treatment, health promotion and mental health. We also kept the people with intellectual disability in the public conversation, which we felt was really important, through easy read materials, but through radio interviews, press statements and blog posts. And we shared others' resources. So we collected resources that many services in Ireland, indeed, including St John of God, have developed a lot of very nice materials, as well as other colleagues at an international level And we've gathered all of those resources together and we included those on our website. Clinical information, health promotion, information around people living with autism and family and caregiver supports, etc. So it became this reservoir in terms of that people could access resources quite quickly. We also held a series of webinars which were very much aimed at the ID sector and supported the ID sector. And we held a series of those across the pandemic, and you can see the title of those there, and they're available to download for people who hadn't been able to join some of those from the website. Well, we've already had over 6,500 people attended the webinars, and we have had thousands of downloads from those presentations. So people found those quite helpful, particularly at the start of this pandemic. We also wanted to look beyond the medical response and infection control, and we wanted to understand how people with an intellectual disability were adapting to what was called the new normal and what they were doing differently. And we sent out a call to people with intellectual disability from all over Ireland, and we got thousands of submissions of the wonderful artwork, images of what they were doing, poetry, stories, etc. And we created a very nice short video clip, which is on YouTube, celebrating the creativity, innovation and resilience of people with intellectual disability during the pandemic. And this is also available on our website to download. But when we begin to think about the risks around COVID, we now know that there are two different risks for populations. And the first risk is there's the increased risk of adverse infection outcomes. So that is the outcomes if you get the infection, and there's increased risk of contracting the disease. And I just want to talk a little bit to you about those two issues. So firstly, if I look at the increased risk of adverse infection outcomes, we know now that those most at risk are those who are age 70 and over, those who have an organ replacement, receiving cancer treatment, severe cystic fibrosis, severe respiratory conditions, asthma, COPD, heart failure, diabetes and obesity. We were then able to look at the data from Adhd and look at some of these conditions to help us understand who would be more likely to be at risk with an intellectual disability. And what Adhd taught us was that those with mild to moderate intellectual disability were more likely to develop and have diabetes. The likelihood of developing diabetes increased with age, and women were more likely to develop diabetes than men. So these were high risk. We knew now that this was a population at increased risk of poorer outcomes. We also knew that obesity was now another health risk for poorer outcomes from COVID-19, and we understood that 80% of people who were older with an intellectual disability were overweight or obese, and this indeed was comparable to the general population with the data yielded by Tilda. Those with mild to moderate intellectual disability are more likely to be obese, and those living in community group homes and living with family were more likely to be overweight or obese, and women were more likely to be obese. So this raised concern of the potential for poor health outcomes for this population. We also showed that hypertension rates were less in this people with intellectual disability than the general population. They were more likely, though, to increase with age, and there were higher rates of hypertension in women than in men. So this was important data that we now had at a population level in Ireland for people who are aging with an intellectual disability. And then looking at the second major issue, that was the increased risk of infection, those with increased risk of contracting the disease. And we now know that people living in residential settings, healthcare workers, people with reduced capacity to understand and to adhere to health guidelines, and other occupations requiring close proximity. Just having a quick look at what the international data is telling us, and this is changing, of course, all the time. So some of the data that I'm speaking to, is probably old at this stage, but we are keeping abreast on what's coming out. So UK study looking at data to May, what they reported was similar overall case fatality for people with an intellectual disability at 5.1%, and those without ID at 5.4%. but that there was higher mortality rates in adults aged 18 to 75 years with an intellectual disability at 4.5% compared to those without an intellectual disability. A Welsh study, again looking at data from March to May, showed similar mortality rates for people with intellectual disability and the general population, but that age standardised rates of deaths for people with ID was 3 to 8 times higher. A Dutch study, which has more recent data, reporting up to the end of October, suspected COVID-19 infections. They looked at 3,490 people with ID. 67 patients with a confirmed diagnosis had died, and mortality rates of 11% were reported among people with ID with a confirmed infection. So this was quite high. Pauline Haslip's work looking at the UK study, she reviewed 50 deaths of people with intellectual disability from COVID-19, increased infection risk with mobility impairments and mental health needs, increased mortality risk for those with epilepsy, and 1 in 5 of reviewed cases were discharged from hospital, but they were readmitted soon afterwards. And UK and Ireland looked at a review of 66 deaths of people with ID from COVID-19. A mean age of death was 64 years, younger than the general population. Observed high rates of moderate to profound ID, 54% of 43 people, so they were at increased risk. Those with epilepsy were also increased risk. Those with mental illness, dysphagia, and Down syndrome and dementia. A UK study estimated a 4-fold increased risk of hospitalisation and a 10-fold increased risk of death related to COVID-19 for people with Down syndrome. And this was after adjustment for cardiovascular and pulmonary diseases and care home residents, which explains some, but not all, of the increased risk. So then just looking at increased risk of infections in other residential settings and comparing general nursing homes and intellectual disability settings. So we know that 22% of nursing homes accounted for 22% of all cases and 56% of all deaths. And this was up to the end of June. So this was in the first outbreak. And the biggest source of outbreaks was private nursing homes up to the end of October. ID residential settings, there was no evidence of comparable widespread outbreaks, and that was up to the end of October in ID settings. So this is of interest. HICWA assessment of nursing homes identified characteristics of outbreak-free facilities. And what they reported was those who were outbreak-free were compliant with regulations assessed, comprehensive contingency plans, proactive and resourceful regarding resident safety, quickly implemented infection prevention and control measures, they were vigilant in monitoring residents for symptoms, and they adhered to the public health guidelines. And HICWA highlighted previous gaps in clinical governance and linked with community health programs, compliant with regulations assessed, comprehensive contingency plans, proactive, resourceful regarding resident safety, quickly implemented infection control measures, vigilant in monitoring resident symptoms and adhering to public health guidelines. And HICWA called for review of staff skills and skill mix to ensure access to enhanced nursing staff and advanced nurse practitioners. And HICWA findings were supported by the Nursing Homes Expert Panel Group. And I think when intellectual disability services, we had intellectual disability or a good level of perhaps of nursing support within the system, and I think this was particularly helpful during this pandemic. HICWA and the Nursing Home Expert Panel also questioned existing models of residential care in Ireland for older people. And for people with an intellectual disability aged 55 years or above, less than a quarter, 23%, now live in residential or more congregated settings. And the largest group within this cohort, 38%, live in group homes in the community, which typically house less than 6 residents. So this may be a factor in the different infection rates between ID services and older person services, and it has certainly shone a light on the like of the unsuitability of large congregated settings, either for people with an intellectual disability or indeed for the frail elderly. So I do hope that this causes a change in direction in terms of long-term care provision for people who are aging. The international literature has also identified increased anxiety and depression and other mental health impacts of the COVID-19 crisis, and an elevated risk of mental health impact of COVID-19 in those with pre-existing mental health disorders. So this was also a concern and should be a concern for us, because what IDS-Tilde has shown us is that over half of the IDS-Tilde sample, 52%, reported a diagnosis of a mental health disorder, and this was prior to COVID-19, and 32% reporting anxiety, 16% reporting depression, and 15% reporting mood swings. Inclusion Ireland did a survey of the impact of day service closure during lockdown, and they reported a 33% increase in anxiety, 38% increase in behaviours of concern, 56% reporting significant loneliness, and they also reported that 30% reported a positive experience by day services closing down. So I think there was something to be learned, and we need to listen to the voice of people with an intellectual disability as we begin to reopen and build back services. Family Carers Ireland survey of the life course of carers during lockdown, they also reported that 63% were concerned about declining health and well-being of the person they cared for. 60% of carers were concerned about their own mental and health and well-being, and 56% concerned about increased challenging behaviours of their family member. So as we begin to build back better, I think the UN, the United Nations, has developed a policy brief, a disability inclusive response to COVID-19. And while building back better, it is critical that people with disabilities are part and parcel of the response which countries are preparing. And these responses, if well designed, can address the exclusion and discrimination faced by persons with disabilities, thus creating more resilient communities and systems. So I think that is important. I want to thank the team, and this is my own team here at TCID, but I also just want to say to you that we have administered, we were in the middle of wave 4 of IDS-Tilde when the pandemic struck, and we went back and we have administered a COVID-related questionnaire to all our participants, to over 750 participants and their carers. We have had very good health data, so it's a really unique resource over many years. And we will be publishing the COVID report, will be launched by the Minister for Disability on the 3rd December. And I'll give you more information on that. So this will be a COVID report on older adults with intellectual disability that were enrolled within IDS-Tilde, and we will be launching that on the 3rd of December to mark International World Day of Intellectual Disability. I just want to again thank all of the people who've been involved in the work we've been doing, particularly our participants, families and carers, our various committees, advisors and our funders. And all of the information I've spoken about can be downloaded from our website, and that is a web address here. Thank you.
Thank you very much, Mary, for highlighting the additional vulnerabilities for persons with intellectual disability. And we look forward to the launch of the COVID report in December. I'm now moving towards the end of our speaker presentations, and I'm delighted to welcome Mary Morrissey, bringing her clinical and research expertise to the morning. As clinical psychologist in the area of diabetes in Connolly Hospital, as psychology lead for HSE Research and Evidence Team, and her leadership role from prior training in UCD, TCD, and Harvard Kennedy School Government. Of particular relevance to the current situation that we find ourselves in Mary has been providing psychological wellbeing support service to staff in Public Health East. And Mary, this has never been more needed. Her topic this morning is the impact of COVID on healthcare workers. Thank you, Mary.
Hello everybody, my name is Mary Morrissey. I'm psychology lead with the HSE Research and Evidence, and I'm principal psychologist in Connolly Hospital. I'm delighted to talk with you about the impact of COVID-19 on healthcare workers. I'm going to cover something about the research evidence, the causes and factors which reduce stress, a service I provided to Public Health in the East, some learning points from surveys, and then some pointers about future delivery. So first of all, it might be good for us just to have a reflection question. And if I could ask you all, how has COVID-19 had an impact on you? Has it been increased stress, disrupted sleep, improved focus, closer relationships, strained relationships? Maybe it's affected your finances. Maybe it hasn't had any impact on you. Or maybe there's something else that we haven't covered there. What I found from my own experience of working, providing psychological support, is that actually all of us have quite an individual experience of COVID-19. What the research has found and is finding is that although most healthcare workers are resilient and cope with the stressful, challenging experience faced during COVID-19 over time, that some people do develop depression, post-traumatic stress disorders, and anxiety. And obviously that we are in an extraordinary circumstance, and that in a sense that our reactions are normal to extraordinary circumstance. In the research, sometimes people have spoken about the risk of moral injury. This has particularly been strong in the UK. And this is really the profound psychological distress which results from actions, or lack of them, which violate one's moral or ethical code. And we will have heard of maybe for people where there was a shortage of ventilators, where people were found, healthcare workers were found to have to choose between a patient to save as a priority, and how that would impact on and create a moral injury. What the research has been finding is that what works is psychological first aid. There's lots of studies on this, and what it involves is the providing practical supports, making sure that people have all the basic needs addressed, resources in terms of kind of mindfulness and support on stress, and also where somebody needs to be referred on and is having mental health challenges, that availability is there. Mindfulness has also been found to be a good practice when supporting people to cope, foster resilience, reduce burnout, and reduce the risk of developing mental health difficulties. And I'll talk a bit more about that. So what causes stress for healthcare workers? What has been the big sources of it for people? One area has been actually remaining in role while others were redeployed. On the Friday the 13th of March, there was quite an amount of people who were redeployed. It happened to me myself in being redeployed. And then for people who were remained in their work, then they had additional pressures. Being asked to work from home, while for some people it is fine, for others, it is an extra burden, as we know, and does create some isolation. I think a very common theme for everybody, a source of stress, is actually having increased new responsibilities and increased workloads. It certainly seemed to be evident for many people working that this is a huge issue. Obviously, losing a colleague or a service user to COVID is huge stress and causing great sadness. Working with at-risk groups in nursing homes, homeless services, travelling community and direct provision have also been challenging for healthcare workers. And then working in high pressure acute and community settings under change working conditions have all contributed to stress. Factors which help to reduce stress obviously do include better staff training and education. I mean, none of us expected this in a sense. Okay, we saw what was happening in Italy and in China, and yet being able to provide staff training on either psychological first aid, reducing stress, or else for some people it was actually having staff training on areas that they hadn't worked previously. Stronger perceptions of organisation support. This is a key area for staff, feeling that yes, the organisation is behind us and also really with us. But this was kind of key to helping people feeling that they're not managing this on their own. Peer support and clear communication. It's been interesting that recent discussions about resilience is saying that resilience is more than within the person. It's actually built up between the bonds between people. So in that sense, it's really core and key that we have support from each other and that there is clear lines of communication. For those who had to work very, very long extra hours, it is important that the compensation for extra and provision of appropriate clothing is basic. I thought this was really interesting about the psychological response phases to COVID. And I'm sure many of you can identify this with this as I can myself. So in the beginning, we heard again what was happening from other countries, and it did create an anticipatory anxiety. Was this going to happen in Ireland? Could we flatten the curve? Then we kind of got into the active phase where a lot of people were characterized by heroics, the surge to solution, and people, I found that healthcare workers did work very, very long hours. We all did. And there was a kind of a feeling of, gosh, we're all in this together. We're in the trenches. And that was followed by a sense of maybe disillusionment and exhaustion, maybe around, say, May, June. And then finally to a recovery phase, maybe it was around the end of June, when people felt, okay, well, we coped kind of well. Some people might have experienced resentment. I think what's interesting is now is that we're kind of, we're back into a kind of a second wave that, you know, looking at post-recovery, after waves of difficulty like this, what is reported to be required is that people get a proper thank you. Thank you for all the extra work, for the different type of work that you were doing, for the efforts, for the support, for communicating well with your colleagues and supporting each other. And also having, telling people to make sure that they rest, that they reset the work, and then that there's monitoring and ongoing support. I could see these stages in the work that I was doing, and I did find that in communicating with the teams that I was working with and part of, reminding people of those 3 points from Professor Greenberg actually were really, really helpful. So the service I was providing and continue to provide is to provide psychological support to public health in the East, and was really deployed to do that. So this involved providing some weekly psychological support emails with 2-minute mindfulness recordings. This practice really was established in looking at seeing what would be a good way to connect with people and provide the resources. And this seemed to be the best way, and knowing that every Thursday the email was coming. Providing a psychological first aid service was saying that to everybody, you can come back, ring me, and I am available if this is needed. Collation of distilled resources. Like in the beginning, it was hard to know, what is the research saying about providing psychological support to a pandemic? What is going to be the impact on healthcare workers, and how can we provide the resources? So ensuring that getting the support from the library and getting all of the resources, this really helped. Also making sure to have continued weekly meetings with the public health managers and contact with public health leads. So I conducted a survey at the end of June after sending the 10 weeks of weekly emails, and found, asking people how they experienced the emails, and people found that mainly they were of value, they were supportive, and they were a good resource. Some other people did find that they didn't have time to open them, and also that others weren't aware of the service. So in terms of staff experiences, other things, people found that, as we know, the impact of COVID on healthcare workers is that people found that they were stressed. Mostly people were working long hours. I also found that people were finding that forgetting to care for themselves, that, taking the breaks, making sure that they had 2 days off together at the weekend, but found that there was so much pressure that they were almost forgetting to look after their own needs. They found that usual supports were diminished during kind of lockdowns, that it was very difficult to actually have the outlet of sport or interest, that and also contact with family and friends sometimes. I found that the small breaks, we know from the literature, small breaks help the neurobiology. In particular, with mindfulness, for example, most of you will be looking at a screen now, a rectangular screen. So if you look through, you'll see that there's a short part and the long part. One small exercise, if you'd like to do with me now, is to breathe in through the short part, pause, breathe out through the long part, pause, breathe in through the short part, pause, breathe out through the long part, pause. And maybe you want to do that 2 more times yourself. So it's short exercises like this that are important to give us those little breaks, and that I found that healthcare workers found helpful. Sleep was actually a key issue. So many people said that their sleep was disrupted. That, as we know, it's restorative, and it helps function effectively. And remembering to go to bed early and not to be using the devices in terms of the phones and not having them there was something that people found helpful, and pointers on sleep. Meaning and gratitude was interesting. Obviously, there's huge impact of losses, and also then reminding us to be grateful for what we took for granted. And this was noted to me that people did experience that, and also feeling more connected and needed as part of a team. Another survey is the recent national survey of HSE staff, and looking at the wellbeing issues, there were 4 key issues that were identified as being important for healthcare workers. And this was in terms of ensuring that the working environment is safe. That is something that people did say, is there, like, if I come into work, am I at risk? Can I be sure that there isn't a lack of any supplies in terms of hand sanitizers, making sure that the environment in terms of social distancing is adhered to. The issue of isolation and working from home and social distancing has resulted in reduced daily interactions, as we know. People miss those chats at the water cooler, as they say. And the virtual coffee mornings seem to be something that can certainly help. We've heard about the concept of always on. Combining work and personal space, as we know, has led to some poor working habits, and then trying to make sure that people are taking the breaks and not working late, and also having signposts. Some people have said that they lack clarity on what supports are available, and this was actually interesting from some research that was done in Galway. People saying, yes, managers telling people that there is psychologists is available, and we're saying, where are they? They want to know where are these available resources. Flexibility has become a big issue, that the COVID has placed additional burdens on many staff, and additional flexibility in working has proved to be important for people. So in summary, really, that the impact of COVID on healthcare workers, the basic needs of healthcare workers can be forgotten, but are really important. Like, I found that ensuring that people were able to take breaks, that they were able to connect with each other, ensuring that while people are working at the weekend, if the canteen wasn't open, that food was available. Healthcare staff do, as we know, experience stress and uncertainty. So ensuring that there is that support and clarity that can help with this issue. We found that staff were working outside their roles. People did say to me things like, I'm totally out of my comfort zone, but they were flexible and found that team working was really important. Working from home, as we know, is positive, but also leads to isolation. And a key message is the importance of providing psychological support to healthcare workers to manage stress and anxiety during a pandemic. So what should future services be like in terms of providing psychological support and looking at the impact for healthcare workers? Flexible and responsive services. I found that these points have really got from looking at the surveys, and also from my experience providing the services. When staff are extremely busy, the services really need to be tailored to what staff exactly need. I found that in our case, it was in sending weekly emails, distilling information, making contact for staff. People would know the particular day that you'd be there, and building trust by keeping agreements and really showing effort in a kind of a consistent connection. Training and education is crucial, and I suppose the time to, now that we know what was expected, the time to do that is probably after this lockdown, and maybe continuing as well, including kind of resilience and other additional training on stress management and well-being. Access to resources. Staff would say to me that they can't have big attachments, that it's really helpful if a lot of distilled resources can be in a clear way in a link. Understanding staff needs, really being able to use the surveys, connect with people, and understand the kind of self-management of stress needs that people have, and putting the supports in an easy way for them to access. We know that psychological first aid is the best evidence way of providing psychological support, and I think it would be helpful for all managers to be trained in psychological first aid. John Hopkins services, they provide some training. I think it's a 6-hour training, and there are many other areas that can provide such services. Leadership. Quite a number of staff found that they were catapulted into different areas of leadership which they wouldn't previously have had. So that in that sense, they would need support on leadership, and also for the leadership to be very visible and supporting. Collaboration. I thought it was interesting that there was a stage where actually the health and well-being, mental health area was getting quite crowded, that there was a real surge of responding. So in a sense that it's important that all the elements of the organization collaborate well and be clear about who's organizing what and in what way, and that is and supporting each other. And future planning, I think this is, as we know, unprecedented. It is really crucial that we listen to what healthcare workers need, and also then implement the lessons learned. Certainly some of the key lessons were communicate, 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 and also really remembering to take time and to breathe. Thank you very much.
Mary, thank you very much for that. It was great to end with that focus on staff well-being. I think what it highlighted for me is the unique and individual experience that we all have with COVID, both linked with the work that we do, the settings we're in, and indeed our own individual lives and family issues at home. What's really excellent is to have resources. You are a bit overwhelmed with material, and that can add to your stress apart from trying to help. So it is lovely. I'm going to look at that link, which I wasn't familiar with, drstevenslibrary.ie, as soon as I get a chance. So thank you. I'm going to welcome our panel back now. If everybody can come on board and show your video screen so that we're able to see whoever is presenting. I want to thank all our speakers again, and thank you for joining us in the panel. And I'd also like to welcome Nicola McGlade, a senior clinical psychologist in St. John of God. Welcome, Nicola, and thank you so much for joining the panel. As I mentioned, I'm going to ask a question to each of our speakers just to get the discussion going a little bit. Some of these questions have been sent in ahead of time by some of the attendees, and many of them can also come, although I'm not sure how many we'll have time to deal with, but please do use the chat function if you wish. Brendan, if you don't mind, I might start off with you, and thank you very much for separating both mental health issues and psychological distress from mental illness, because I think sometimes when one is reading the literature, you can get confused whether it's from prevalence data or indeed service provision or planning, and it's confusing to both clinicians and service users. But I was particularly interested in the US study that you presented, the electronic health records, and the increased risk of individuals with newly diagnosed mental illness, a gamut of disorders, and the risk of them having infection with COVID. I wanted to ask you a couple of things. One, I wasn't clear, I haven't read the study and I will do, whether this was a prospective or a retrospective recognition of COVID infection. Did one follow the other? And the other thing was maybe if you could talk a little bit about whether it was due to behavioral issues of mental illness. I was interested that ADHD was there, for example, where somebody is quite impulsive and in your face and social distancing can be hard. But obviously we're aware of those issues with mental illness. Is it because they were unable to adhere to the restrictions, so they were putting themselves more likely to be at risk? Or even if you controlled for that, was there some vulnerability within those that have a mental illness to actually being infective and, as you say, having a worse outcome?
Well, thank you, Fiona. This was a study of electronic patient records in the US. So we are clear that the diagnosis of mental illness came before the COVID infection. What's not clear is precisely how the higher risk of infection is mediated. So we know from before that public health advice tends not to reach people with mental illness in the same way or to the same extent it reaches other people. The prime example there is stop smoking advice doesn't seem to have the same impact, or it's not couched in such a way as to have an impact. So in a sense, this isn't an enormous surprise. The figure for ADHD was really interesting and certainly surprised me, but it's not clear if this is because failure to provide public health advice, failure to adhere it, or maybe some of the symptoms of ADHD. It is clear that this is a real finding, though, because it has started to be replicated elsewhere. And this does suggest from a public health perspective that if we are to focus public health advice on specific groups and try and make it a little less generic than it currently is. This is a group of the population in need of, if you like, bespoke public health guidance, both for themselves and for the broader population's benefit.
Thank you, Brendan. Joseph, if I might ask you a little bit with your experience in working with young people, it's interesting that about 17% of COVID infections are happening amongst the 15 to 24-year-old. And we're aware of many of them are asymptomatic. They're less likely to be seriously adversely affected, although they can be. And I wanted to talk a little bit maybe about behavioral change. At the moment, there's a little bit of, concern and even at times public anger about the fact that young people are partying. Temple Bar area is live at nighttime. But at the same time, you have to be mindful of the huge impact, the restrictions, apart from the infection, but the restrictions have had, as you very well presented in your talk. How do we get this particular cohort of young people to change so that they are able to adhere to the guidelines as is being requested of them?
I think it's a very, very important question, Fiona. And I think sort of almost building on some of what Brendan was saying there, it's about how do we target messages to a particular young cohort. When we talk to some of the young people who work as youth advisors for Jigsaw, they would say that a lot of the messages, the public messaging, have been through very traditional media forums, through newspapers, through radio, that are not geared towards young people. So it's about, and I know there was some discussion during the summer about using social influencers to try to influence some young people's behavior. But I think young people are very aware that some of the social influencers are usually about selling something, and that you might need somebody with a bit more gravitas to actually give the message for young people. So I think one of the aspects is around how the message is being sent and received and being understood. The other element, I suppose, is really difficult for what young people are talking to us about, the peer pressure that they're under sometimes for people saying, oh, come on, let's just meet for a drink, because we need some time away from our parents, we need some time away from home. The whole point of adolescence, I suppose, is that journey into adulthood and developing their own identity and formation and pushing against the boundaries. So I think that there is a clear cohort of young people who are struggling to try to achieve their independence, but doing that under these new rules. And they usually, there was a lot of other structures that we had in society about people, having social clubs or friends or various different pubs, various different ways for people to use and have a structure. All those structures are gone. So I think it's about thinking about the messaging for them, but also thinking about a bit of empathy as well, in terms of thinking about what is it like actually to be a young person today when you're told you can't do anything. And some of the young people, what they're saying to us is there a way of having a positive message? And is there a way of engaging young people themselves? And one of the things we've been able to do in Jigsaw is give young people the platform. They've chosen TikTok particularly to make some short films to communicate to other young people particularly about our work and about the availability of services, but also about looking after their own mental health in a very preventative way. So I think young people would be part of the solution. It's about opening that up and thinking about different ways of communicating, as we would with various different other groups within the public health sphere.
Mm-hmm. I mean, I think you're right about the videos in TikTok and, the meaningful messages that can be got across. And also, it just reminds you how innovative young people are.
Yeah, absolutely.
Yeah.
I think solutions there, yeah.
It's difficult, though, because at times you're beginning to get the public anger. And, if you look at everybody, the surveys they do, how many people are adhering to the guidelines, we all say we're adhering, but we all say you're not adhering as well as
Exactly.
I am. Yeah.
Exactly.
Thanks, Joseph, and indeed for all the good work that Jigsaw is doing.
Thank you very much.
Ruth, if I might talk a little bit about, you presented very eloquently about the risk among the elderly and the elderly with mental health illness. And later on in the presentation, the fact that, the nursing homes suffered, particularly in the beginning of the pandemic, but less so as the pandemic continued to increase, although rates in the elderly have continued to go up, but it wasn't the same extension in nursing homes. Is there anything, do you think, that we've learned from the first lockdown and the rise within the nursing homes, and that's making it a little bit different this time now, both in nursing homes and I suppose the impact of lockdown. I'm thinking a little bit in the beginning where there was such emphasis on elderly's cocooning and not coming out at all. And we were dropping groceries to our elderly parents and aunties and not going into their buildings. And I guess at the moment there seems to be a little bit more understanding about you are allowed visit if it's to care for and support. And that includes not just medical care, but that social support and mental health care. Do you think we have learned things from the first time round that we're beginning to do this time that's making it a little less socially isolating on the elderly, be they in nursing homes or in the community at home? And just to unmute yourself, Ruth.
Sorry, apologies. Thank you. Yeah, I think we have learned, definitely for older people, certainly at home. The first lockdown was exceedingly difficult, and people were afraid to leave their houses at all, not even to go for a walk. And sometimes some of my therapeutic intervention was to say, go for a walk, and go for a walk every day, stay away from people, be fine. So I think the second lockdown has meant that older people, as you say, there is this bubble that they can create with another household. People can visit a little bit more. They do feel a little bit less restricted, and the cocooning word, I think, has disappeared almost from the language, which I think is a good thing. So I think from that perspective, I think things have improved, although there's probably a way to go, because there's still a lot of negativity around about, that the older people are the ones who get the infection. The younger people are the ones breaking the rules, and the older ones are getting the infection and obviously are at higher risk of mortality and morbidity with their comorbid risk factors. When it comes to nursing homes, I'm not sure how far we are in that. The visiting restrictions, I think, are really enormously stressful for both people in the nursing homes and for their families, because at the moment still a number of nursing homes, I think quite a proportion, do not have any visiting at all, and not even window visiting, so one cannot see one's nearest and dearest. I think it's very distressing for the people resident in the nursing homes, because of their, so many of them will have a level of cognitive impairment, may well have dementia, their cognition deteriorates, and they become more agitated, distressed, and confused because they're not sure what's going on. So I think we have a way to go within the nursing homes. I also think we need to look at nursing homes. Is that the best way to manage our older generation? Is that the best way forward? Is that the best that we can do for them after all their years they have given to us? I just pose that as a question.
I know Ireland is probably better than some places like the States, where there's less reliance on these very, very large nursing homes, for the care of the elderly. We may not be as good as some of our Scandinavian countries, where there's maybe a lot more community support. But I guess one of the big issues was staff, moving between nursing homes and double jobbing on account of the fact that, maybe, financially they needed to do so. And it highlighted some of the difficulties around the lack of testing, quite apart from the lack of PPE. Do you think, that's contributed significantly to lower rates this time round in the nursing homes and better recognition? And it touches in a little bit with what Mary was saying about, Mary Morrissey, about, healthcare workers. Do you think it taps into a little bit more of an awareness of the needs, not just to look at the nursing homes themselves, the residential settings themselves, but also, I know visitors have been stopped, but obviously staff need to continue to go in, but maybe some awareness about limiting staff between places.
Certainly, and I think there have been concerns about how to manage that as well, with the some of the nursing home staff being recruited then into the HSE, and the difficulties in getting consistency of staff going in. Certainly from an infection perspective, yes, that we know a lot more. Now there is serial testing, testing every fortnight or whatever it may be, and that limits the amount of, yes, the infection rates are going down. So I guess I was focusing more on the psychological impact, or the impact on the mental health of people within an environment where there is no visiting and restricted outlets for them.
Thank you, Ruth. In terms of the residential settings within individuals with intellectual disability, Mary had mentioned that, you know, fortunately the numbers are much fewer, and that makes it obviously a much more kind of family home environment situation, but I guess in some ways reduces some of the risks of the larger spread. But notwithstanding that, Mary, I wanted to ask you a little bit about maybe some of the ethical challenges. Individuals with intellectual disability, and indeed individuals with old age and dementia, where there's a lack of an awareness or an understanding about the virus, the need to follow the restrictions imposed, you know, what behaviors reduce infection, and you spoke a little bit to this in your presentation. But how do you balance, you know, the needs of the residents and, you know, allowing them, as they would in their own home, to be a little bit more independent and to make these decisions themselves, from the risks to those that are looking after them or linked in the residential homes with them? The kind of the balance between the individual right versus, you know, the collective rights and staff rights as part of that.
Thank you, Fiona. Yes, so this, of course, is a challenge, but I think people with intellectual disability themselves have shown great resilience. And many people with intellectual disability we have seen were actually, in the study that we'll be talking about in a few weeks' time, were actually able to adhere to the guidelines. So, you know, I think that was really interesting. So people with intellectual disability adhered very well indeed to the guidelines. But yes, there are challenges where you know, people may not understand the high risk that is posing to somebody else, and it is trying to manage that in the most ethical and least restrictive manner that you can. And it may actually mean maybe that the person you have to take it on a case-by-case basis and a house-by-house basis, and see what will cause, you know, the less risk to somebody, but also the less distress to the other individual. So, you know, there's not a simple recipe book you know, I think you just really have to take it on a case-by-case basis. But people with intellectual disability have been quite, you know, able to comply in a way that we may have perceived prior to this, that you may have had difficulty in understanding the regulations. They've actually been very able to understand and compliant.
And
I'm not sure if that answers your question, Fiona.
Pardon?
I'm not sure if that answers your question.
No. I mean, it's fantastic to realize that it hasn't been as much of an issue as I might have, without being in your area and working there. I might have worried that it might have been. Fortunately, I don't have any more toddlers left in my household, but I can see at times when you're trying to, you know, help somebody adopt a new behavior. But what I have found, Mary, working in Crumlin in the emergency department, psychiatry, a lot of young people with autism who might have been, and intellectual disabilities, who might have been quite used to and benefited from a structure and having respite care and having access to going to school, particularly in the beginning. And there was a huge increase in presentations when all of that structure and routine was removed from them, that led to a lot of additional challenging behavior, I guess, for parents at home. And that challenging behavior for us as clinicians was also difficult to manage in the hospital, because, you know, we were trying to do so whilst, you know, one didn't know the COVID status of ourselves or the young people, and you're trying to protect everybody. And so it certainly was, from my perspective, a clinical worry. It sounds like you're suggesting that that hasn't been as much of an issue that you have found.
Well, yeah, we have found, I suppose, on one hand, there was the belief that people with intellectual disability wouldn't be able to adhere to the guidelines. And yes, what I'm saying is that a large proportion of people actually were able to adhere to the guidelines. But there was a proportion of people who found, the same as the rest of society, living within the restrictions quite stressful. the loss of routine, the inability to visit family and friends, just particularly, not being able to get to work. And I think for the first wave, perhaps, that people were thought this was for a certain period of time, and it was new, and people kind of rode into it. But as it went on, the pandemic went on and stretched over the summer and now stretched into the autumn and Christmas, it's becoming more difficult. But I think, it has been challenging time for staff and family carers, and the reports show that families have been, their own health and the health of the person they're supporting has absolutely been negatively affected. So I think many services now in ID have really tried, and they do need to try to open up in some way day services for people, but also to be innovative in creating. I am working with a number of people now with ID who have got dementia, who are very stressed about and finding it difficult to understand the fact that they can't see the family member, and it's very stressful for the family member, and it's very stressful for them, and we shouldn't really underestimate that. And we have to look at innovative ways to support people who are suffering that psychological trauma and psychological distress of not being able to see the family member and recognize it and pay heed to it. And I think that's what's really, I think is extremely important, because sometimes we may, just feel, well, that's the way it is, where I think we've got to understand the emotional toll that this is having on people.
And do you think services are doing enough to kind of consider, that really, basic need to meet your family member? Are services doing enough to consider, could that be done safely whilst still adhering in general terms? Because as an individual, if I want to go and see my mum who's elderly, or my dad, it's a decision I take to go into their house or not, or to meet them out the back garden or not. And nobody's applying the rules to me. Whereas I guess if my parents lived in a residential setting, albeit small, I would have to follow the rules of that organisation, where there's that conflict between minding staff and my parents and the other residents in that unit. Do you think organisations and residences are thinking carefully enough? Are they able to be to have a little bit more leeway at times when necessary?
Yeah, I think that is a very important issue, and I think there's variability in what's happening across the sector, and there's some people very innovative, but there's also people who are, organisations are, absolutely terrified that, COVID is going to get in. But really what I'm asking is, how many visitors have been the source of spread? And I'm not 100% sure about that, and I really would like to see the data on that, because very often it is asymptomatic staff, or when you have very widespread community transmission, that puts the risk. But nonetheless, there is a lot of anxiety at the moment, probably even more now within ID services, that if COVID comes into this group home, but they're associating that with perhaps visitors coming in, with family visiting, whereas I think the biggest risk is probably staff and people who don't know it. So I think we've got to realise, as Brendan and others have spoken about this morning, just the impact for people not seeing their family, not being able to see, or their impact for families and not being able to see their loved one, and realise that this is a critical issue, and particularly as Christmas approaches, and we're still going to be living in a COVID world. And I know we're going to be running something in the next week or so around saving Christmas for people with intellectual disability who are living in care. We're going to run a webinar on that next week, and this is really trying to encourage these real issues for people with intellectual disability. So yes,
Mary, love to chat about it further, but I'm going to move on to Mary Morrissey as the final panelist, and then maybe open it up if we have time. Mary, what I'm interested in, and thank you so much for all the work that you are doing in this space. Do you think any of what you're doing now personally, or what the HSE might be doing by way of policy developments, have been informed by good exemplars that we might have understood from other not quite disasters, because fortunately we haven't, apart from bad influenza seasons, but we'll say other systems analysis or internal inquiries where they have caused a huge amount of stress to the healthcare workers, you know, trying to do a good service, trying to meet the demands of the service, always constrained with resources such that we have in Ireland. Has there been good exemplars of how to help reduce staff burnout and stress level, you know, that are now kind of shaping some of the work that either you're doing or the HSE rollout advice?
Yes, thank you. I think that what we really learned, I suppose, from other disasters was around the importance of psychological first aid, and that being providing practical supports, having resources available and knowing where to refer people on, and that being different from, say, debriefing. I suppose they learned from the 9/11 that debriefing people was re-traumatizing. And that, in a sense, I think that what the pandemic has highlighted would be how, you know, people who normally wouldn't have experienced stress probably in their work currently are because of the circumstances. And I think the exemplars really are, I found that using the library, the National Library, Health Library and Knowledge Service in the HSE, provided a lot of rapid reviews, and in that sense ensuring that people would have the I suppose knowing that the information was there, knowing that they prioritizing their own self needs, their self-care, ensuring that they were, as they taking the breaks, looking after each other. And I think that we found that looking at what was provided in other jurisdictions in terms of psychological care, I think that also then looking at what the best practices is in terms of having the resources available, but also testing out in what different groups needed. And I found education seemed to be quite important for support, you know, giving people information, say psychological first aid. Make sure that you're looking for safety, ensuring that keeping the social distance, seeing is everybody else doing okay, listening to each other in quite a deep way. How are you doing? A little bit more than just how are you doing, and noticing, and then linking people. So when people knew about the look, listen, and linking, that these were exemplars.
Thank you, Mary, for that. I'm very mindful of time. It's a particular area of interest of mine, occupational stress of burnout, and I guess we are aware from research in Ireland that pre-COVID that level was already quite high, and with COVID, the demands that are going to be placed on our mental health service in general, there is such a need to look after ourselves, but maybe we have to leave that for another day. And I might just point you to a UCD conference we ran on occupational stress. If any of the attendees, the recordings are there on the UCD Child Psychiatry website. But Mary, I'm sure I'll chat with you more about it.
Yeah, actually, I meant to just add one more thing, which is really that the HSE developed a program, a 5-module program on minding your minding your well-being, which is launched just in the last 2 weeks.
Well-being, that's another thing to look up. Thank you. Nicola, you've been sitting quietly there. Thank you very much. And just from your experience of working in an organization with all ages that we have been talking about, both the young and the older population as well, and also having staff working round the clock, being innovative at the same time, minding their own families. What has your sense been of, I guess, challenges and opportunities that maybe COVID-19 has brought for services, for how we adopt, and you know, whether you're seeing areas that actually still need an awful lot more support or attention to?
Well, I think COVID-19 has brought changes, and some of the changes that it's brought have been very good. I mean, the kind of people adopting Zoom and other technologies to communicate and to deliver therapies and deliver, you know, kind of support people who can't physically be with you. certainly it's something that we had to move to quite quickly in our outpatient department. Luckily, on the inpatient side, you know, we've had to adopt certainly our practice, but not as much as those on the outpatient side. I suppose there's been a lot of challenges across the board. I think, you know, for some people working from home has been a welcome change. For other people, they found that actually quite difficult and have had to adapt and certain, you know, kind of manage certain ways. Certainly, I felt very lucky leaving the house every day. My husband, who was used to traveling, you know, at least once a week, suddenly found himself grounded at home, working from home and homeschooling 3 children, which didn't help as I skipped out the door.
Yeah,
Much to my delight. But, you know, so initially, I mean, there was that change for him. And I think a lot of people who had traveled a lot enjoyed being at home, but now find the grind of it. And certainly watching how that's all been managed and talking to different friends of mine and different people that I'm working with therapeutically, the different things that they've adopted. So a lot of people are starting, you know, have taken on doing their kind of commute to work, which is the walk in the morning or a cycle in the morning to then come back in to their house, into their office. My husband texted me the other day as well to say about his canteen. He'd just been downstairs to the canteen and they were serving pizza and a glass of red wine for lunch, which he was quite excited about. So kind of, I suppose, enjoying those little pieces. Finding the enjoyment in things, I think, is very important. And I think a lot of people have been doing that. And certainly a lot of the communication within groups, I know the kind of parents WhatsApp groups, the community WhatsApp groups have, there's been a lot of tips sharing and a lot of reaching out, which I think is lovely as well. I certainly have noticed more of a sense of community around the place, which I think was something that had been lost over the years. I know working with older adults, and when I talked to them about their experiences of growing up and of raising children, there was always a lot greater sense of community involvement than I was experiencing myself. And I think that has come back, that, you know, I've noticed people are talking an awful lot more to each other in the villages, in you know, out and about. You tend to be greeting people an awful lot more, and I think that's nice. And if that can be continued, that would be lovely. You know, I mean, one of the biggest challenges is that loneliness piece. And I suppose I was interested that Brendan had identified that females tend to be more vulnerable to mental health difficulties, but we've actually seen an increase in St. John of God's, particularly in the later life teams of men. So, you know, I kind of wonder about that and maybe what's happening there. Yeah, so I think there has been, you know, there are nice things that are coming from the pandemic, and if we can bring them forward, I think that would be fantastic. But I do think loneliness has been a big thing. Connection is so important for people, and there's something about the physical connection, you know, that Zoom and these cannot replicate. And I think anywhere that can be replicated, again, being flexible in your thinking, how can we do this? How can we meet up? I'll just finish an example of my mum, who was, my dad died just before the pandemic really kicked in. So my mum found herself cocooning for the first time ever and on her own, and not being able to have that support. So we did things like the back garden coffees, and we did virtual hugs where I got her to put her arms around and give herself a hug, and I did it, and we imagined that we were hugging each other. She now meets her friends in the local park, and they bring their camping chairs and they bring their picnics and they have their coffee and picnics while social distancing. And it's that kind of flexibility. How can we keep the connection with other people, and even that physical connection, because that is just so important. And I love the idea of that being continued. And even anywhere you go now, you see people sitting on walls having coffees, people sitting in a park having a coffee, much more so than we ever did before. And I think that would be lovely to bring forward.
Nicola, I'm so sorry for the loss of your dad just before. And I guess, you know, it also reminds us of the individual differences that we're all bringing, and you as a healthcare worker, you know, having to go to work and continue despite all the additional stressors that you're under. And I guess it's a resilience to all of us that as healthcare workers, we continue to do this. And as you say, we look to take something more positive from COVID and hope that it can build a better future. Unfortunately, I have to end the session this morning. I do agree that Zoom doesn't quite do it. Number one, the good thing is you're not all shouting over each other. If this was a real audience panel discussion, we wouldn't get a word in edgeways. But thank you all for being so, you know, I suppose, generous with your time this morning. And indeed, as always, I would just like to say that I do too miss that social connection. We're very much socially driven people. And I must say that St. John of God's, in my view, I've been working here 19 years. And it has always had for me that hospitality and that connectivity and values social nurturing the spirit. And I think that the series of research seminars that we have run over the last week and next week really is part of that. Just by way of closing, I'd like to draw your attention to next Tuesday for all the listeners. That the topic of the conference will be on research, the challenges and opportunities, really the experience of research over the 30 years, and I suppose some of the difficulties which we didn't get a chance to discuss ourselves this morning. It'll be chaired by Professor Mary Clark, and we'll have the opportunity of presenters coming from St. John of God, not just in Ireland, but indeed in Africa also. And again, all services will be covered. You know, St. John of God has child, adult, old age, and intellectual disability services, and also very importantly from all perspectives. So everybody, thank you all so much. I hope you all stay well, and as to all our listeners as well, I hope you've just enjoyed this morning's presentations. And although we can't have a water cooler or a coffee to chat further, I hope that we'll see each other maybe with the vaccine sometime soon. All the best, and thank you. Slán a bhaile.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thanks very much.